Hello, everyone. 2 years ago, we gathered in Toronto for the first international symposium on APS type 1. At that time, we were honored to welcome Dr. Uli Kampa and Dr. Eystein Husby from Sweden and Norway, respectively, who spoke eloquently and convincingly about the importance of European APS type 1 registries in their keynote addresses. I encourage you all to watch videos of these talks on the APS type 1 Foundation website. I am incredibly grateful for the support that Dr. Kampa and Dr. Husby have given to our small but growing APS type 1 North American community over the past 2 years. You are not only brilliant scientists, you are also very special people. Thank you for making the long journey to be with us in Stony Brook. Today, we continue this pattern of world-class keynote speakers with Dr. Michail Lionakis. Dr. Lionakis is well known to many of the doctors, patients, and families in this room, but I will take the liberty of reintroducing him on this special occasion. Dr. Lionakis is the chief of the Fungal Pathogenesis Unit, Laboratory of Clinical Infectious Diseases, National Institute of Allergy and Infectious Diseases at the National Institutes of Health, the NIH. He is a physician scientist who obtained his MD and SCD from the University of Crete in Greece. He did his clinical training in internal medicine and infectious diseases, and research training in mycology and immunology at MD Anderson Cancer Center, Baylor College of Medicine, and the NIH. In 2012, Dr. Lionakis was recruited as a tenure-track investigator at the NIH, where his laboratory research focuses on understanding antifungal immunity in patients and mouse models. Since 2013, as part of his laboratory's clinical research program, Dr. Lionakis has recruited more than 75 patients with APS type 1 APECED at the NIH via his IRB-approved clinical research protocol. This program is aimed at better understanding the mechanisms of autoimmunity and fungal susceptibility with a goal to develop improved diagnostic, preventative, and therapeutic strategies for APS type 1 APECED patients. Now, this official bio does not do justice to the work that Dr. Lionakis does at the NIH. He has created an outstanding team comprised of experts in endocrinology, immunology, rheumatology, infectious disease, GI, hepatology, pulmonology, dentistry, ophthalmology, dermatology, and I don't know what else. But there are two very important elements of the patient and family experience at the NIH with Dr. Lionakis' team. First, the patients are listened to by each and every team member. Second, the team, and especially Dr. Lionakis and Elise Ferre, are determined to improve the patient's quality of life as soon as possible, and usually before they leave the NIH campus. This mixture of compassion and determination to help our patients is magical. Today, Dr. Lionakis' keynote address is titled APECED in 2017, Current Developments and Future Prospects, and I can't think of a better person to give it. Thank you so much. I introduce Dr. Lionakis.
Well, thank you, Jennifer, for this very kind introduction. It's really a true honor to give you this lecture here in front of you. I'd like to thank Jennifer, Robin, Heather and Todd, and Sherry and David for the invitation, and then for the, I think, magical organization of this meeting. It's interesting that we are at the 20-year anniversary of identification of the AR gene, the cause, the genetic etiology of this syndrome. So this was done in 2 independent groups that used heroic positional cloning strategies in 1997 and reported the autoimmune regulator, gave it a very good name without really knowing what that did until Mark Anderson 5 years later discovered that. What I would like to do today is really two things. One, I want to convey a message that these 20 years, we've really gone a very, very long way. And I see Eugene somewhere in the audience, who is our oldest patient, although he looks great. Sorry. And you can talk to him about how difficult it was growing up, not only between 1997 and now, but way before. He's here with his grandchild in this meeting. And in the process of these last 20 years, I would like to highlight, that's one of the goals of this talk, to highlight the major contributions that many people have made in order for this to be feasible, to have patients have a better life now. And these include Mark and Uli and Eystein. I'd like to start this by, I think, joining me in a round of applause about all of their contributions through the years. And then what I want to do is to give you a perspective of mine that have not been involved that long in this disease, but over the last 4 years, as Jennifer said, we've had a rapidly growing cohort of APS1 patients where we've taken a very, very systematic approach, both from a clinical and a research standpoint, to try to understand this disease and help the community as a whole. So the way I'm going to do this is in 4 sections that relate to clinical presentation and diagnosis, pathogenesis, which is going to be the bulk of my talk, then talk a little bit about some fascinating new findings on the genetics and how this might help us explain some of the variability we see in this disease, and then not talk too much about treatment because you'll have to bear with me later on at 3:15 about that, but give a couple of slides of overview of how we think we in the future, maybe the next 20 years be here or earlier, to talk about historical problems at that time. So starting with clinical presentation, earlier from Matt's endocrinologist, we saw the first report in 1929 of APS1 patient. These are 2 others from 1943 in an endocrine journal and then in the JCI. This disease, 10 years later, made it in the New England Journal of Medicine as a clinical pathological grand rounds. So this is a disease that is frequent, as was mentioned earlier, in some parts of the world, in Iranian Jews, and Sardinians, and Finns. It has a frequency of about 100 to 200,000 in many European countries. It's unclear how much it is here in the States. It's probably around the order of 1 to 200,000 to 1 to 1 million. I think we'll have to find out. Now, it presents with a multi-organ autoimmunity and a signature infectious disease, chronic mucocutaneous candidiasis, or CMC as I'll call it. And that's a very characteristic presentation for primary immunodeficiencies. Pablo yesterday talked about how many rare diseases, and Robin earlier about the 300 plus primary immunodeficiencies. This characteristic constellation of endocrinopathies and candida is quite unique, which has made actually life easier, believe it or not. When you have a primary immunodeficiency that presents with enlarged lymph nodes early in life and then it manifests with other things, that differential diagnosis is much broader and makes even more challenging problems. So this is summary data from European cohorts where you can see highlighted endocrinopathies being common, candida being predominantly seen, and then non-endocrine diseases such as vitiligo and hepatitis being less common in that part of the world. So what we decided to do in 2011-12, so I'm an infectious disease internal medicine trained physician, and I come from a line of training where I trained with physicians that looked at the patient as a whole, which is not, unfortunately, what happens in private practice, especially in this country these days, where you have about 10 minutes to see a patient, and if their symptom is not really aligning to what your specialty is, you send them to another 35 patients, and they never come back to you. So I'm allergic to that process. So I'm in a place at the NIH. I'm in a place where actually I can practice medicine without that being a problem. I don't bill, I don't count the minutes, and we can spend 15 hours if we need to that week with our colleagues to talk about a single patient in order to think through what's going on. And being in at NIH where the research environment is conducive to world-class research, this for me was a no-brainer to be there. Now, how I got involved in APECED is, coming from a fungal standpoint, and as Jennifer alluded, because of that interest as a physician, first of all, and as an internal medicine doctor, primarily, we decided to take a more systematic approach. So not just bring patients at NIH to swab their mouths, and if they complain anything about burning in their mouths, to send them somewhere else. This would not have been possible without ELIS through the last 3-4 years. Would not have been possible without a phenomenal group of people that, for the first time, the last 60 years, the clinical center is open at NIH. This protocol has brought, for the first time, 11 different institutes out of the 28 of the NIH in a multidisciplinary team that was carefully put together of academicians, clinicians, and scientists who do care and have an interest in trying to help patients and understand this disease better. So some of them are listed here. So what we did, and that started with Todd, who came without Heather. I don't know why back then, maybe. And Gabby, in 2013, I don't know if you remember that, in the outpatient clinic, when immediately after you, actually, we started this uniform evaluation. But Gabby never had Candida problems. She actually had kidney problems. And that didn't make us less interested or more interested than in any other patient. And that unbiased enrollment, I think, is powerful. And coming from the NIH in a place where we see dozens and dozens of these rare diseases, a major problem of them is that they're referring or physician or scientist who might have an interest in X or Y or Z biases his interest and his findings because he or she would report on Candida, for example. So we have developed a model by which we will enroll anybody, and we will do a uniform evaluation that is painful, I know. It lasts about a week. But the benefit of that is that we will get a very systematic view of all aspects of this syndrome, plus, very importantly, not use healthy donors as our control, but rather APECED patients who don't have the corresponding X or Y, Z manifestations as their control for what it means to have malabsorption or kidney disease. So this is a list of what we do. We have the same physician scientists from these specialties see all of the patients, whether they complain about cough or not, doesn't matter. We get the same blood, urine, and stool studies, imaging studies, and then we do procedures when they're clinically indicated, and we use some of them for research, as you know. In brief, we've come across, I think, two major discoveries that relate to the patients we've seen here in America. One is that this is a disease that clearly affects endocrine systems, but also a lot of the diseases that we see here and their manifestations do not map to the endocrine system. I think this is important, so we all disseminate that finding to all of the US physicians that see patients, so we don't rely on the endocrinologists that want to see them when they're like 7 or 8 years old to make the diagnosis. And then something that was also highlighted even before we got into that from the Scandinavian literature, that the diagnostic diet can happen late. Here's a couple of snapshots of these summaries. So you can see here on the left side. So first of all, we've identified over 33 different disease manifestations that can happen. And 5 of them are endocrinopathies, and the remaining 25 plus are not. Some patients actually have more than a dozen non-endocrine manifestations. The problem with that is that when they go to any physician, that knowledge is not there. So they're ignored until they go to an endocrinologist eventually to get the diagnosis. So that is a problem in this country. Earlier, it was pointed out that these 6 specific manifestations we find particularly enriched in our cohort based on our evaluation. So these include intestinal malabsorption, hepatitis, gastritis, pneumonitis, an urticarial eruption that is very early on, and I'll come back to just a minute, and then Sjogren's. With regard to how good the diagnostic diet is, when you are a 3-year-old or when you're a 4-year-old, or where you have you're a parent and you take your 1.5-year-old to the doctor, the answer is we can do better. And that's based on this data. So the mean age of making a diagnosis, and that's in part to the Scandinavian experience, is about 7.5 years. But in only 20% of the patients, the first 2 consecutive manifestations that they will go to the doctor would be among the classic diet. In other words, 4 out of 5 patients will keep developing things. There are going to be 3 of them in median, and the range can go up to 10, which is scary, before they develop 2 things that would make somebody say, that reminds me of APS1. Now, we also do a horrible job in this country and in other countries as well, but speaking of this country, of even when they have the classic triad manifestations to make a diagnosis, and I'm not going to elaborate that. You can talk to every patient here, except for Matt. So there is a big gap here and a great opportunity to educate and increase awareness in order to make lives easier. So these are three just representative examples. A patient who had candidiasis and malabsorption when they were 1 and 2, then waited a few years to get the classic endocrinopathies, or candidiasis and malabsorption, then keratitis, and then went 2 decades to get adrenal insufficiency. Or what Pablo described yesterday as well, that's not him, but urticarial eruption and CMC, which is quite common the first year of life. Then another 7-8 years go by until endocrinopathies get picked up. So in our systematic analysis of the first, this is data on the first 35 consecutive patients, and I'll show you the validated data in a minute. Actually, urticarial eruption and CMC are the 2 most common disease manifestations. They usually happen the first year of life. Now, the problem with that is that when these patients end up in a dermatologist or an immunologist, people don't think of APS1 even in the differential. So they think of Job syndrome, or they think of DAC8 deficiency, or they don't think anything. But certainly APS1 is not up in the list, and I think that's a problem. And this is a problem not because it's not good to not do what you're supposed to do as a physician, but because it has a very, very characteristic histological picture. So yes, urticaria happens in kids, but this is not the urticaria that happens and lasts for a day. It lasts for a few days. It has no identifiable medication, vaccination, or other cause. It typically is not blanching and non-pruritic. It's typically without a fever. I don't know whether there is an undiagnosed viral entry, or this is the first kind of manifestations of T cells coming out autoreactive and going crazy. I think we'll have to find out. But when you look at histologically, there is really a very characteristic myeloid and lymphoid infiltrate, which is quite different from what classical urticaria will look like. So there is no eosinophils, and combined lymphoid and myeloid infiltrates, the differential should not be more than 3 or 4 things, and APS1 should be there. And that has major implications, obviously, we'll discuss through this talk with regard to diagnosis and management. When we looked at what manifestations could happen early, we came up with this triad of urticarial eruption, enamel hypoplasia, and intestinal dysfunction that happened, as you can see, quite early, similar to what the classic triad happens in this cohort at least. And when we could combine the two and ask the question, what if we don't wait for 2 classic manifestations to happen to call this APS1, but we take the expanded triad, we could make the diagnosis in retrospect, obviously, 4 years earlier. And half of the patients that would end up with conditions that were discussed by the panel earlier would have been diagnosed before. When we look at the next set of unbiased consecutive patients, so this on the left is the next 28 patients from the US, as well as 8 patients from Europe, from the UK, Ireland, and Germany, the data appear to hold true. And if we put all 71 patients in this data set, again, the median time of diagnosis would be close to 2 years as opposed to 6 years. Now, this is not meant to say we need to change the diagnostic criteria. It means to say that these patients are not going to be seen by endocrinologists until they have many more problems, at least 80% of them. The spectrum is broader. We need to educate physicians of multiple specialties for that. You could argue what's the cost effective, we're in a country where that matters, what's the cost effectiveness of screening 10 kids that have urticarial eruption and candida and only finding 3 of them. I would argue, and we'll see tomorrow with the panel that we have about undiagnosed disease, but there are ways to do this in ways that would not be that cost problematic. Plus, if we talk about a devastating disease that can be diagnosed early, it does matter, even if we just pick up 1 out of the 10. So I think a key message is that in this country, this disease is more likely, or at least as likely, to be seen by the least of all of these specialists that you see here. And this has major implications to make a diagnosis early, not because half of them or more or less will not develop adrenal crisis or hypocalcemia, but as you'll see later on and at the 3 o'clock talk, there are windows of opportunity to intervene with immunomodulation early on to potentially change the natural history of the disease. And we cannot do that when somebody is 24 years old and already has 7 manifestations, but maybe we can do that when they're 1 or 2. Now, I'm going to spend some time in the field of what we know about the AIR gene, and that was in 2002 when Mark, when he was in Christoph's and Diane's lab, really not only put light on how APS1 happens, but really put into a different level our understanding of innate immune tolerance. So a question that boggled immunologists for decades. And we had a very nice schematic earlier on. So what that really recapitulates is that AIR is mostly expressed in the thymus, although it's in other places. I'll come back to that. And through the expression of tissue-restricted antigens in the specialized cell type called an MTEC, through AIR, all of these autoreactive T cells that would get clonally deleted, and in the absence of AIR, that doesn't happen, so these can escape in the periphery and cause autoimmunity. And this was very elegantly shown, and others have reproduced it since then by Mark's work, where if you take a bone marrow chimera mouse experiments, that is, if you take a mouse, you lethally irradiate it, you wipe out all of the hematopoietic cells, but you leave the thymus in there, then you put a wild type or a knockout AIR-deficient bone marrow, it really maps to the stromal compartment. The thymus is critical for this. Now, the immunological shadow that AIR projects in the thymus is not for everything. It's quite elegant and it's specific. And a couple of years ago, this paper came out that described another transcription factor that you see here, that through direct regulation, as opposed to epigenetic regulation that happens through AIR, can modulate expression of a different set of tissue-restricted antigens. Not surprisingly, these knockout-deficient mice were having a very different phenotype that AIR-deficient mice have. So they had autoimmunity in the skin, in the kidney, and in the brain, which is not typical features of the mice in the patients. So that probably means that there might be patients out there that have these mutations and they present with autoimmunity that might have some overlapping, as you see here, but also mostly divergent manifestations. Now, again, back to Mark's work, when these CD4 T cells that are autoreactive are actually sufficient to cause tissue injury. That was shown both by loss of function and gain of function experiments, if you will. So this is one representative example. If you deplete the CD4 T cells, you improve your histology scores. If you make genetically modified mice that lack T cells in the AIR-deficient macro, the same applies. And importantly, if you take AIR-deficient CD4 T cells alone and you put them in a mouse that doesn't have AIR deficiency, that alone can cause autoimmunity. So that is important. More recently, there have been reports about how AIR does other things, and we'll highlight briefly a few of those. In addition to negative selection of autoreactive CD4 effector T cells, AIR also promotes the thymic development of regulatory T cells. And that appears to be critical very early in life, in neonatal kind of stages, or very early in life. That was shown by Christophe and Diane. And Pete's work also alluded to the fact that there is critical components of AIR in modulating T regulatory cells. Now, the relative contribution of AIR deficiency on the effector versus the regulatory T cell compartment, I think, is difficult to be 100% certain of what it is. But I would say the data in mice, but also importantly the phenotype of the patient, would argue that the negative selection is really the most critical as opposed to the positive selection of the regulatory T cells. A couple of examples. So this is again Mark's work. If you do a thymic transplant in a mouse that doesn't have a thymus, and that is an AIR-deficient thymus, that mouse develops autoimmunity. But if you co-transfer both the wild type and a knockout thymus, now the wild thymus will provide the wild type regulatory T cells. That is not sufficient to prevent autoimmunity. If we also take a human disease that we have at NIH and we follow patients with that, it's called APECED, that they specifically lack regulatory T cells because they have mutations in a gene called FOXP3. Their clinical presentation is completely not overlapping with APECED patients. So these patients get very severe autoimmunity early in life. They have diabetes, no other endocrinopathies. They have glomerulonephritis, not interstitial nephritis. And they get enteritis as opposed to the lack of neuroendocrine cells that APECED patients have. So the clinical phenotype of a deficiency in Tregs in humans is distinct from that of APECED patients, which speaks for although that AIR regulates T regulatory functions in mice and in humans, it would appear that what Mark described in 2002 is the predominant mechanism of how thymic T cell selection or negative selection happens. Now, to me, this is an intriguing summary slide. So there's been very fascinating data, in my opinion, on the organ-specific roles of non-CD4 T cell lymphoid cells. Not because they have intrinsic expression of AIR, although B cells might in some conditions, but because of thymic-derived defects in the AIR-deficient background. So, for example, Maureen in Mark's lab back in the day showed that if you transfer AIR-deficient CD8 T cells, you can get nerve autoimmunity. The depletion of gamma delta T cells appears to specifically affect the retina. And again, Mark's work in double AIR-B knockout mice, particularly affecting the lung. That is very interesting conceptually, but also think of potential opportunities as far as targeted therapies when somebody has X or Y, Z manifestation, if we better understand how these effectors come into play and synergize in order to cause organ-specific autoimmunity. So I think this is a fascinating area. Now, I'll spend some time on B cells. And the three potential mechanisms by which they might be causing disease is by production of autoantibodies. Although in mice, direct serum transfers for N-deficient mice, both in Diane's lab and in Mark's lab, haven't shown directly to cause disease, as for example in arthritis or uveitis or diabetes models. Now that doesn't necessarily rule it out, but it speaks that there might be other factors. And those presumably could be B cells acting as antigen-presenting cells, or as recently shown in the mouse thymus and in a recent Jackie paper in human B cells from the thymus, there might be B cell expression in some thymic cells, AIR expression in some thymic B cells that might contribute to central tolerance. But I would like to focus more on autoantibodies for the next few slides. You'll see very obvious reasons. So whether they're pathogenic or not, they've been a wonderful diagnostic tool. So type 1 interferon autoantibodies, as you can see here in work from Europe, even before the clinical diagnosis where the patients would have positivity for alpha, beta, omega, and that would last for years. So this is something, again, we'll discuss tomorrow, and how this could potentially be incorporated in diagnosing patients early before they come to clinical attention. I would like to highlight a couple of decades worth of tremendous work by Uli, who has used these autoantibodies to really inform us of what autoantigens in an organ-specific manner are targeted in these patients and other patients, and these have been great lessons for autoimmunity. So that relates to parathyroid, it relates to the gut, it relates to the adrenal glands, it relates to prostate and potential implications in fertility, to the pituitary, to the lungs. I could go on and on. The importance of this is not only that some of these are important prognostic or diagnostic markers, but also, as in that very last example that Mark and Uli published, the autoantibodies were not only markers of lung autoinflammation in APS1, but also in patients who have interstitial lung disease. So these could be actually important beyond APS1 in certain settings. And I think Uli is actively looking into that in other contexts, and I think there will be informative for more common diseases, which always brings attraction for research beyond having a baseball player get APECED, which might happen at some point. Now, whether the autoantibodies in every setting are pathogenic, I don't think we'll get a verdict today. But there was this paper came out of Adrian Hayday's lab in Cell last year, which provoked, I think, a very, very intriguing thought. That is, could it be that some of these autoantibodies that these patients make could they confer protection against specific disease manifestations that, although we have a widespread syndrome here, I told you they get 30, 35 disease manifestations sometimes, but they classically don't get a few others. So the example that was used in this paper was the type 1 interferon autoantibodies with diabetes. We've discussed that with Adrian yesterday. We haven't, in our hands, been able to reproduce that specific particular correlation. But I think the concept is quite intriguing. These patients don't get lupus. They don't get rheumatoid arthritis. They don't get glomerulonephritis. So is that because they might carry autoantibodies that confer protection for those? I think this is a very, very interesting area, and I think we'll hear more, obviously, tomorrow as well, and I'm sure this is not only in one direction onwards. I think major questions that we have about B cells, really we don't understand the mechanisms of B-cell breakdown of tolerance. Is this in peripheral? Is it in central checkpoints? Eric Meffre has taken it upon through patient samples from the NIH study to try to understand that. He's gotten some really cool conclusions that I'm not allowed to disclose yet. I think I alluded to how autoantibodies can be useful. Uli spoke earlier about the 21-hydroxylase in patients who have adrenal insufficiency. But when we see a patient who is 6 or 7 or 9 or whatever age, at the individual level, not every single autoantibody is predictive of something, and I think we need more work as a group to try to use that as a predictive or a prognostic or a diagnostic tool. I think we have the potential to do that. And then, although we know that there are autoantibodies that target specific autoantigens, and then there's been elegant work about specific autoantigens targeted by T cells, we don't really know systematically whether those two completely overlap, meaning, are we missing autoantigen targets that are not seen by B cells but only by T cells and vice versa? I think that's an important area where we can expand. Now, AIR doesn't only do this. It mediates apoptosis differentiation of these cells. It's important for expression of chemoattractants in the thymus. And I don't have too much time to go into this, but again, Mark, a few years back, came out with a very elegant story talking about AIR expressing cells that are outside of the thymus that are critical for inducing tolerance. I think if we take into consideration patients who have thymomas, or patients who have inherited RAG mutations that develop autoimmunity, both of which have been clearly shown to have significant decrease in AIR expression or even absent in some cases in the thymus. Yet though these patients do not develop, are not a phenocopy of APS1 at the clinical level. That means that they have different disease manifestations, which raises, I think, the possibility, and I'm sure we'll hear from Mark over the next few years, well, how in the absence of AIR expression in the thymus, there might be extrathymic AIR expressing cells that might pick up some of that cargo or compensate. So I think this is going to be a fascinating area, and I think conditional AIR knockout mice will conclusively tell these answers. So I think we still have major questions that we need to clarify. So what targets the spleen? What targets the salivary gland? About the nails, I'll show you later on. I'm not so convinced that the ectodermal dystrophy is not a non-autoinflammatory autoimmune attack. So that means that there are probably targets in the nail or in the skin, both for vitiligo and for alopecia. So I think Uli has much more work to do to tell us in the future those. And those could be life-saving. So for example, 3 weeks ago, we almost lost a 27-year-old patient at the NIH who has asplenia and developed fulminant pneumococcal sepsis, grew strep pneumo 3 hours after blood drawing in her blood cultures. And the only reason she's alive is because she was lucky enough to be at the NIH for a routine visit and was found to just not being well. And she was in the hospital, and that's why she's still alive. So having a marker, for example, to predict those that will develop asplenia, because these patients are born with a spleen. And it's not a common practice to do ultrasound on a yearly basis, nor looking on a peripheral blood smear these days. So I think there are major implications for patient care on that. I think one of the areas where we've started getting very interested is the T-cell repertoires from patients who have different organ-specific disease states, different stages of disease, and before and after treatment. Can we learn about predictors of response, about predictors of autoimmunity in different organs based on CDR3 hydrophobicity and other markers? I think patients develop carcinomas, not very often, but they do, and how that happens I think is important. And then my favorite bug, which is Candida, I don't think we still understand how they get Candida. So although I gave you, I think, how we understand autoimmunity happening, how a deficiency in a thymic transcriptional regulator makes you get vaginal or oral candidiasis, it's a bit odd. Quite fascinating of a question. And it's not because people haven't looked. We have looked, others have looked through the years. But we've looked in systemic parameters. So these patients have autoantibodies against IL-17 and 22, and we've verified these. But as reported by other cohorts, the correlation between them and Candida is not more than 70%. So that speaks for potentially other factors. And that got us very interested in defining this. These patients have normal innate immunity, and that's consistent with the fact that they don't get systemic candidiasis, and they don't get frequent infections. And their cellular immunity has impairments, but nobody so far had looked at the site where infection happens. And when it comes to Candida, although it's the same bug causing infections in the bloodstream and the mucosa, it's as distinct of an immune response in those two sites that looking in the blood is actually irrelevant, as would be looking in the vagina would be irrelevant for a pulmonary infection by Candida. So our hypothesis the last 4 or 5 years, starting into this, was that patients develop this infection because they have problems in their mucosa-specific immune response. Now, it's easier to say that that is to study than do it. But being at NIH, we've developed, in collaboration with our dentist colleagues, assays where we can actually interrogate mucosal immunity from patients. And then we've also, to test this hypothesis, we modeled oral candidiasis for the first time in air-deficient mice, which, as opposed to wild-type animals, these are fungi in the tongue that after 5 days they control it. They're unable to do so. That can go up to 2-3 weeks if you look. Those mice do not get systemic candidiasis. They do not get viral or other infections, so they're actually a phenocopy of the disease when it comes to infection susceptibility. And in their mucosa, this is 5 days after infection. These are normal-looking tongue papillae, and they're free of fungus. This is a stain that's called PAS, and it highlights fungi in magenta. It's like a party of Candida on the surface of the air-deficient mouse. So what I can say is that there are more factors to the autoantibodies that have broader implications beyond APS1 when it comes to Candida susceptibility. So I think that's going to be something that soon we'll be able to disseminate more. Now, a major problem was alluded earlier is 50% or more of patients actually develop resistance to treatments that are orally available. And we're fortunate to partner with people who develop new antifungal drugs. So this is one, it's called VT1161. These are mice that lack IL-17 signaling, so this is kind of a surrogate of what typically we see in patients who have IL-17 deficiency, including APECED. And what you can see is that for fluconazole is able to maybe not tremendously, but significantly decrease the fungal burden. This is a drug that now is phase 2 trials. It's very safe. It's been given for patients who have vaginal candidiasis and mucormycosis. It has a long half-life. It can be given once every 2 weeks. So for diseases like this, that patients have to live with Candida forever, that might be a way to go. We'll have more work to do, obviously, but that's probably coming up. And I think there's no licensed fungal vaccine yet, but there is one in phase 2 trials from Jack Edwards' lab. So there might be possibilities in the future to vaccinate, boost immunity, and not have to worry about this. So in this summary, I think we've learned through the years that AR pleiotropically modulates cell-specific functions in the thymus and beyond that have implications in the development of organ-specific autoimmune manifestations. And I think more research on the role of AR will shed light into the mechanisms of immune tolerance, and I think will enable for the development of more targeted therapies for patients in the future. Now, with regard to genetics, this is a very nice written review in Current Opinion Immunology by E. Stein a couple of years back. So there are 14 exons in the AR gene, and there are mutations in all of them. There are some more hotspots than others, but you need 2 mutations to have classical APS1 that are scattered through the genome. Now, I'm going to make just 3 observations briefly, because this could be a topic that can go for a while. I think we've all highlighted and we've all observed a dramatic phenotypic variation in patients with biallelic disease-causing mutations. So I'm going to give 2 examples of that, 2 extreme examples. So isolated hypoparathyroidism with disease-causing AR mutations has been highlighted. This is a paper from the US. In a paper that was published from the Scandinavian countries in a small group of people who had isolated hypopara, actually 8% of them had APS1 when you would look with genetics and with autoantibodies to type 1 interferon. I'm pretty sure there are patients who have isolated other manifestations. I don't know whether that's been found in Addison's, isolated Addison's, in Scandinavian countries or here, but I'm pretty sure we are underestimating how many patients have single disease manifestations, especially those that don't fit into the diagnostic triad. I mean, we do a horrible job diagnosing those that have the diet, not to mention like a single pernicious anemia or vitiligo. I think more work is needed on that. And then, obviously, the patients, including siblings, that have dramatically different disease manifestations, although they come from the same genetic background, and although their environment wasn't that terribly different, up to an age at least. So I think all of these speak for, I think, a very important concept. So these are monogenic diseases, but really they're not. And we see that on and on in every single primary immunodeficiency we see at the NIH. This is not specific to APS1. That means that they're gene modifiers, either promoting susceptibility or ameliorating susceptibility in the context, for example, of isolated hypoparathyroidism that we have to go out and find. And so, for example, we subject our patients to whole exome sequencing. We start doing whole genome sequencing now on everybody. I think that's the future. The proof of concept was recently provided by Mark's lab and DeFranco's lab, where in a mouse that lacked both AIR and this gene called lean, while in single knockout deficient mice, the frequency of uveitis was almost not there, half of those that were double deficient develop uveitis, which says that there are probably genetic variants outside of AIR that affect the phenotypic expression in an organ-specific manner. So we're looking actually at this in our whole exome sequencing data. We'll let you know what we find, Mark. And then I think there are multiple such opportunities and many things that can be tested, certainly in mice, but also in humans to generate hypotheses. Now, I think beautiful work from Estein's lab, I keep butchering your name, I'm sorry, was published in 2015. So there was a paper from Italy in early 2000s that showed that dominant negative single heterozygous mutation in locus in position 809, which led to the G228W protein, was sufficient to give you APS1 type disease. This was predominantly a thyroid disease at the time. I think this was put in the much broader scale, focusing on the PHD1 domain. So this is elegant work showing an AIR-dependent gene in transfection systems. This is one of the common hits from that Norwegian cohort. This is that one that was described before in Italy, and Mark made a mouse out of it. And these are classic non-dominant negative mutations. What you will appreciate here is that when you add a little bit of that, even 25% of that mutant into 75% of wild type, you completely mess up the 75% of wild type. So these act in a dominant negative fashion. And this is critically important because they don't present like the full-blown APS1, but they present with organ-specific autoimmunity. Vitiligo and B12 deficiency were more prominent. I think there is more to that. They are common. Some of them are as common as 1 in 1,000, which raises important conceptual questions about how AIR deficiency, AIR-specific mutations might actually underlie susceptibility for common autoimmune diseases, which also can raise interest. And I think we have much more to learn from Stein over the next few years on that. And I think I love this schematic. So this really puts this into context. If you completely lack AIR function, you get a lot of autoimmunity. If you're normal, you don't. And then there is this area in the middle. And the gene dosage effect of that, I think, is a fascinating area. And I think we'll learn, because I'm pretty sure that you have patients that have different mutations that probably alter that balance differentially, and I think that's going to be exciting to find out. And then I think the last point I wanted to make here is, up to a couple of years ago, we had no clue what regulates AIR at large and, what's the promoter region and all of that. And then Mark again, and that confirmed independently by Part's group in Estonia, described this NF-kappa-B responsive element called CNS1 upstream of AIR, that if you knock it out, you get a phenotype like you have AIR deficiency, because it's critical to get AIR expression. And this is mice that were made, and they had the phenotype. Now, there's been, I would say, an explosion of genes. This is a gene that affects splicing of intron 2 of AIR and decreases expression. And a lot of other genes that modulate AIR acetylation or demethylation or phosphorylation or ubiquitination, all of which might affect AIR expression. I think we've looked with Mark, and we'll keep looking, for patients who have APS1 phenotype and they don't have AIR mutations, but they have CNS1 mutations or deletions. We haven't found them yet, but I'm pretty sure they're out there. I would even suggest that there might be modifiers of such that might have implications both in the expression, the phenotypic expression of these dominant negative AIR mutations for how the other allele might be behaving, or in the context of autoimmunity. So I think this is an exciting advance. So with my last couple of minutes, what I would like to do is not go into much detail because we'll talk later about this, but I think give you my vision of where we need to go and how we can do this all together. So what we would do currently to take care of patients is hormone replacement. I think there are some important questions that were raised earlier with PTH replacement. Speaking of hydrocortisone given 2-3 times a day not being physiologic, given once a day PTH is really far from it. Antifungal therapy we touched. I think I urge all of you who either are patients, and I mean you haven't come at the NIH yet where you've been tested for that, or physicians, get the peripheral smear on all of them and get an ultrasound. Asplenia calcul. I'm pretty sure some of the patients in the literature that had sudden deaths died from fulminant pneumococcal sepsis. Every patient needs to be vaccinated, and patients need to be on penicillin prophylaxis as children. If they're penicillin allergic or if they're adults, where the literature is more confounding, every patient who is asplenic needs to have a levofloxacin prescription at home, and at fever, they need to start taking it. That applies to the asplenics, not to the others. But about 10% of them, they can deteriorate very rapidly. And again, we almost experienced that 3 weeks ago. I think carcinoma screening is an important place where we need to learn more. So we do gastric mapping in patients who have intestinal metaplasia every 2-3 years at the NIH. I don't know if that's the best way to do this, but we'll find out. We look at, we do dental thorough exams for oral carcinomas. And then when it comes to immunomodulation, which I'll talk later, I think there are ways to stop the end organ disease, and we'll talk about it. I think the way to go in the near future until we find perhaps a better or a more conclusive curative approach, which I think, as we'll hear later, will probably include an immunosuppressive element as well, is to really identify those early patients, children, and start them on treatment with immunomodulation that we know it works for end organ disease that is already established, so it's highly likely it will work as a preventative measure. We actually now have 3-4 children that are in the age of 1 to 3 referred to us at the NIH that only have Candida, and they're prime candidates for that. So we're working on an IRB-approved protocol for that, and you're all going to be involved in this. And I think we'll hear at 1 o'clock both from Luis and Audrey about how perhaps thymic manipulation is either in the sense of transplantation or CRISPR-modified iPS autologous thymus development that Mark has pioneered, how this could be playing a role. I think there are some conceptual hurdles there that we're going to have to overcome that relate to alloreactivity, that relate to the data in mice that if you put both a wild type and a knockout, you still get the disease. I'm pretty sure there are ways that this potentially could be overcome, but that might be something that can be done. So the vision is that early recognition of the disease can lead to preventative interventions that will change the natural history of the syndrome and prevent the development of autoimmune manifestations. And how are we going to accomplish that? And when I say we say I include all of us, patients, colleagues, physicians. I think we need neonatal genetic screening eventually. It's done in countries that are a little bit smarter than ours. Well, until we get there, I think we need to make everybody aware of the multi-organ, non-endocrine nature of the disease, at least in this country. So it doesn't take 10 years for them to get to medical attention. We need registries and we need biobanks, so everybody has access to patients' samples and information. We need reliable clinical phenotyping for that. We've been victims of that, having patients come at NIH with completely misdiagnosed conditions. Well, until we get there, we need to really have free access to patient samples via collaborations. And certainly for all of the scientists that are here in the group, you're very aware that our NIH biobank is available to all of you. We've sent samples to Mark, to Uli, to Eric Meffrey, to Bill, to Diane, and others. And that will continue. I think we need the strategy where we will use early diagnosis in autoantibody screening. I think Uli has some beautiful work on customized arrays that we'll share with you tomorrow. So if we talk about neonatal screening and registries and biobanks and autoantibody screening early, we have to talk and listen to what the people who've done it well, and these relate to countries such as Sweden and Norway, and we have no clue how to do that in our country. And then obviously we need more research and we need clinical trials that are upcoming. So really the desirable outcome is that we'll have patients that were born with AR mutations but live an autoimmune-free disease. I am optimistic that we can reach that so that in 20 years from now, at the next kind of 20-year anniversary of the AR gene discovery or even earlier, we'll be able to be sitting here and talking about how this was a disease that used to cause more troubles than it causes at that moment. So with that, I would like to really thank the patients and their families. So this is Kayla and Gabi, which make it beautiful for us to get involved. As a physician scientist, I could not have dreamt of a better place to be, of a better disease to study. It makes this meaningful, and it's a great experience for all of us at NIH. I think I would like to thank all of our colleagues that really have made it possible for us to be sitting here in 2017 and talking about diseases like that right now. I would again refer you back to Eugene. This wasn't like that even up 10 years ago. And I would like to thank you all for your attention. I will be happy to take any questions.